You're not going to know every step of Tinetti and Berg by heart. Like, I don't expect that. Jerry doesn't expect that. No one should expect that. I mean, when you look at the steps here, it's a pretty strong assessment as far as just how much content goes into that, right? So let's just kind of, because this is one that we hear about a lot, let's just start on Tinetti. And this specific document has a first page on it that is really good for us, because under the interpretation side, it tells us that the max total score is 28 points. So put you a little highlighter on that so that you know. Under interpretation on the first page, max total score is 28. And then it says, in general, patients who score below 19 are high risk for falls. But 19 to 24 indicate a risk. So that's what you really got to kind of hinge on, is that from 24 to 28, there's not much of a risk. But from 19 to 24, there is a risk, but after 19, there's a significant risk. So what that tells us is a Tinetti, we score them, and if they acquire the points, then we start a tally, right? We want to get them up towards 28. So let's go ahead and flip over and take a look. The thing on Tinetti is it's based off of balance and gait. So we're going to look at it today, and then we're going to revisit this when we cover gait next week. But let's just look on that first page where it says, and it's on the back of the first page for you, because I did it, that's the way I did the copies. But the first thing is sitting balance. So what we're doing is we're just sitting that patient and we're seeing what they need. If they're steady and safe in a seated position, feet flat on the floor, and they don't complain of any problems, then we give them the point. You see that? And then if they need to lean or they slide in their chair. So what does that look like? Well, for the most part, we're looking at a patient and asking them to do this right here. But if they have to do this, then that's a 0 point. If they're like, nope, and they really lean back. Now, if they can do this and go back to your grade scale that we did in class, how many minutes can they do it? That's another assessment. We're just looking, can they do this right here without going, oh, no, I can't handle it, all right? So you have to put some context into it. And then, how do they arise? Are they able to do this without help? Do they need to use their arms to help? Are they able to do this without arms? So there's a total of two possible points here. So take a look at what I'm doing here. If I need to use my hands, my arms, right? Or maybe they reach and grab something, then that gives them 1 that they're able to do it. A 2 would simply be that right there. Right, so you're seeing the descriptors. Now again, do you have to remember all of these and be able to do them on command without a list? No. But you do need to have some reference as to how that looks. And what we want you to know is those grading scales, specifically the interpretation. 28 is the maximum. That is you've got to drive that into memory somewhere. And I am going to put that on the test. 28 is the maximum. 19 to 24 means what? Moderate. Basically a moderate. There's a risk of falling there, but they're not at a high risk. And so keep those things in mind. And then where does the high risk come in? Yeah, if they score 19 or below, they're at high risk. So, or 0 to 18, I like that, yeah, let's take that. That's where you really want to be interpreting that this patient's high risk. And these are things that I commonly see at licensure level. They want you to know how to interpret those findings, because you're not going to see many times the full Tinetti. You may be able to look back at the record, but you will see a score. And so does the PTA have the ability to interpret that score? And that's what we want you to be able to do. So we are setting this as a standard right now and saying, no, 28 is the maximum, 19 to 24 is a risk of falling, but anything less than 19 is high risk on Tinetti. Tinetti does two things. It does balance, and on the next page, the last page there on Tinetti, it does gait. And we'll get into gait more next week. Some other things though, to just point out on balance. Sitting balance, can they stand up? Do they need more than one attempt to stand up? So what does that look like? That's probably a lot of this right here. And you've seen your older patients do this before. They'll kind of need, they'll need more, and they kind of have to get that momentum driven. My father-in-law, I have him in for therapy right now, and I'm taking care of him down there in the lab, and I could actually show you some of these examples where he must have hands to rise, and sometimes he needs more than one attempt to get that moving. And so you'll see this more, and just be very specific about what that risk looks or what that point value is. Another one is on their standing balance. This is a narrow stance, what I'm doing right here. Sometimes people will kind of assume a more wider stance if they're having to stand for a longer period of time. The number 6 is our perturbations. So what kind of balance are we assessing there?
Reactive.
That's reactive, right? And so they begin to fall, they stagger, they grab, they catch themselves, or they steady. And then we also ask them to close their eyes. What kind of system are we assessing here?
Visual.
Well, we're taking out the visual. Now let's just be clear. When you take out the visual, you have to upgrade on another system. Very specifically somatosensory and vestibular. Right? So here's what I need you to be very clear at. Is if I take a patient and I shut their visual system down, I'm asking the other two to upgrade.
So would that mean you're working on the other two, you're not working on vision?
Right.
Okay.
Right. So when you take the visual input out, you require those other two to come up. That's called sensory organization. And it's in the very first part of the balance chapter. What happens on number 8 when you turn a patient 360 degrees? What system are you taking out? Yeah. And why is that? Because the vestibular is about head movement.
When you take out what? Just say that again.
When we have a patient turn 360 degrees, we are looking at the vestibular system's input. And when you start moving the head, you're required, well, I'm getting a little bit of dizziness there on myself. You're required to need the other two systems, to upgrade those systems to maintain balance. Now this is really tricky. I don't want there to be any confusion on this. You're using the vestibular input that you're getting, right? But what are you having to maintain balance with? Your somatosensory and your visual. Because you're doing this movement right here is challenging the vestibular input. So you need somatosensory and visual to keep you upright and not fall. When I close my eyes, I no longer have visual input, so what am I relying on? Somatosensory and vestibular.
So if you're trying to challenge the visual, you don't close their eyes? Because if you do, then doesn't that just take it completely away?
That takes it out, yeah.
So you have to do it with what? Like with moving the eyes, I suppose.
With moving the eyes?
Like how you visual, like as in like, moving the head, I suppose.
Mm-hmm. You have to do, and this is just an example of how you can do it. I showed you how to get the vestibular input challenged here, right?
Mm-hmm.
So, when you do that, you're maintaining balance with what? If I'm turning my head, the input is challenged, and so I'm having to maintain my balance with what?
The other two, visual and something.
Right. So look at how it's said, and I'm not going to try to confuse you with my questions on my test.
Yeah, well, I'm just more so confused, like, so if we're challenging the visual system, how do we, if you turn it off, you can't challenge it, you know what I mean? So if you close your eyes, it's like you're not challenging the visual system.
No, you're taking the input out.
Just
so how do you maintain your balance? What I'm saying is, if you take an input out, you're left with the other two to maintain balance.
Mm-hmm.
That's what I want you to walk away from.
During the somatosensory, what would you say for that? Like if you take that one out?
Well, you're not going to be able to take out somatosensory because you're still going to get that from sitting or standing.
So basically, it'll be the visual, or you're going to be testing.
That's visual or vestibular. Mm-hmm. The somatosensory should be constantly challenged. That's the one that doesn't really get a pass. If you're standing or you're sitting, your trunk or your legs are constantly getting that somatosensory input. Now you can challenge those, right? And now I really need my visual and my vestibular right here because I'm going to one leg, but my somatosensory input is really feeding in as well. And that's what sinks into those synergies, automatic, voluntary, and stress reflex, but that doesn't get that out. Finally, we look at their sitting and what they do. If they misjudge their distance, if they fall into their chair, they get no points. Uses arms or not a smooth motion. That gets them to 1. And then safe smooth motion, that's a 2. So there's a pretty simple little setup there, right? We're sitting, we're standing them, we're nudging them, then we're having them close their eyes, we're vestibularly challenging them, and then we ask them to sit. But again, I'm not asking you to memorize those steps, but I do need you to know the scoring. And do you have a real clear concept of how they score that? Okay? We don't need to look at the gate today. We'll look at the gate next time. So let's do this one. Let's go over to our Berg. Berg is very similar. It has sitting to standing. It has standing unsupported. And again, you are scoring this, and you're building a score. You're starting at 0, and you're building a score. And so you are going through and you're giving the best description to your patient based off of what they do. So if they are able to stand, no hands, and stabilize independently, and by the way, you just probably saw that in your Tinetti, but now you're doing it in a different test. Able to stand independently using hands. Do they use hands after several tries? Do they need minimal assist to stand or stabilize? All those things. You just list what you saw, right? And I want to tell you something for future reference. Always put the least of what you see. It's better to score a patient lower than higher because they can always improve, but you don't want to give them something and then watch them degrade. Does that make sense? It's kind of like if I say, well, you know, I know they use their hands, but they don't always use their hands. But if they did use their hands, or you commonly see them use their hands, give them the score for using their hands. And then you're going to continue writing up what you see based off of this content right here. And as you go, you'll see that at the very end there's a total score of 56, right? That's at the very bottom. Anybody remember from rehab what the high risk score is?
0 to
1 to 40. High risk of 0 to 40.
What is it?
0 to 20. 21 to 40 is more.
Okay. What is a risk of falling? Not high risk, but a risk of falling.
21 to 40.
45. Anything below 45 is a risk. And now, let's do our mini best balanced evaluation systems. This is the other paper that I gave you, and I don't think that you saw this one with Ms. Hobday, but I like to print this one out for you guys because it talks about anticipatory and reactive balance. And these are some things that we can use in our interventions. So these are things we can do within the therapy setting. And I also think this gives us a little bit more of a definition or description for what anticipatory and reactive balance looks like. So it gives a line, and then it actually tests sit to stands, rise to toes, stand on one leg, all as being anticipatory. Now, remember, we gave you the definition of anticipatory as being what? Internal or external?
Internal.
It's internal. So, just so we're all clear, the action of a sit to stand, right here, it says cross your arms at your chest, try not to use your hands unless you must, do not let your legs lean against the back of the chair when you stand, please stand up now. So everybody scoot your chair back. Cross your arms. And what I want you to do is I want you to assume the testing position and stand. Right? That is internal. That is anticipatory. Now, just so we're clear, anticipatory, think about that word. You're anticipating what you're going to need. Your movement is all from internal, right? You're all good with that? Okay, so cross your arms again and sit back down. Rise to toes. It says, place your feet shoulder width apart, place your hands on your hips, try to rise as high as you can onto your toes. I will count out loud for 3 seconds. Try to hold this pose for at least 3 seconds, look straight ahead, rise now. So, hands here, come up and up onto your toes. 1, 2, 3, and back down, right? That's the test right there. Again, that is anticipatory, it's internal. Now, we know sit to stands. We do those with our patients a lot. How about adding in a little bit to our sit to stand where they come up on their toes, right? And what are we doing? We're just challenging more, a little more of an upgrade on the system. And then the last one is, and just remain standing for me, stand on one leg, and these are the instructions. And so a lot of times we fumble with our words and trying to explain a situation or an intervention to a patient. It says, keep your hands on your hips, lift your leg off the ground behind you without touching or resting your raised leg upon your other standing leg. Stay standing on one leg as long as you can. Look straight ahead. Lift now. So here, here. And so we're timing them. And look at what it says down below. Normal is 20 seconds. Moderate is less than 20 seconds. Severe is they're unable. And then the same thing with the other leg. So we put a standard on there. Can they do this for 20 seconds? So grab a seat. So when you're thinking about what can I do for anticipatory balance, right? I think there's a skills check question that says, have them do anticipatory balance. Now in class, we talked a lot about rolling a ball and kicking it, right? And you were like, hey, look, who can I have roll the ball if I'm guarding the patient and those kind of things. Well, let me just kind of change the paradigm on this. Maybe you don't roll the ball at all. Maybe you have that patient do what? Sit to stands? Is that anticipatory? Say yeah.
Yes.
What about if they do a sit to stand, touch to toes, rising on toes? Is that anticipatory? Yes, it is. And then finally, you're balancing out 20 seconds right there, right? And you tell them, our goal is 20 seconds.
That's not anticipatory, would it be though? Wouldn't that be reactive? Well, no. It'll just be ankle strategy or a hip strategy.
You're about to see some real good reactive stuff real quick.
Okay.
Those are all anticipatory balances. And so you as the PTA, you're writing that out and you're saying, we're doing this for anticipatory balance. We're doing this for anticipatory balance. And that will probably come up when you get into some of the situations where you're treating more balanced patients and you have to speak that out. Now, your reactive. It says compensatory stepping 3 times, and it will say forward, backward, and lateral. Now, let's just kind of work out what this means. It's compensatory stepping. Remember, stepping is a strategy, right? And stepping comes in when the limits of stability are what?
Push to the boundary.
Yeah, when we push outside of those, they have to step. Now, here's what we've done. We've given you 3 options here. First is forward, and it says stand with your feet shoulder width apart, arms at your sides, lean forward against my hands beyond your forward limits. So Aaron, come join me here. Here is a lean forward into my hands. Come on. Right? And now I'm starting to catch him. See? Step. Right? That is reactive. So anything that the patient has to do where they may have to step, that's a reactive. And then on the lateral, stand with your feet together, arms down at your sides. Lean into my hand beyond your sideways limits. When I let go, do whatever is necessary. So turn and face your peers here. Feet together. Lean into my hands. Lean, lean, lean. When I let go, do whatever's necessary. They kind of get me. I'm sorry, I'm not very good at that one. Like, did you see me flinch? Don't tell Aaron I flinch. Alright, so let's do that again.
So for that, do you only like, do you have a hold of their gait belt,
That's what I'm saying.
or do you, so you're doing, okay,
Let's do it this way. I
Okay.
trusted you on that one. I didn't drop you.
No, I'm just saying, I didn't say.
Our imaginary gate belt was very, very effective. Very effective. Yes.
and so for the first one, you would just have a hold of them in front of,
I would be here and here.
okay.
I saw a picture in the book where, and I was wondering if this would be reactive. They were holding the weight out to their side, and would that be reactive because they're having to, react and lean their body back to the left?
Show us for me. Give us a little better.
Well, just like we were saying, like say this bag was really heavy. I was sort of leaned down, but at the same time, I'm keeping this left side is pulling me up, And so if I was holding this here, it's a heavy weight and already I'm an old person, I have bad balance already, and I have to work to pull it back to the left to keep me into an upright position.
What do you think? Or internal? No.
I would have been
That's what I would think.
Yeah, because wouldn't, that would be your reaction to come back, but are they stepping? I don't know.
I think it would just
Is
be
that-
more of a lean back to the left.
I think because you bring in an external device or weight, then it becomes reactive.
And then see, that's what I've been thinking about just this morning, kind of. So where if you took away the weight because their balance is that poor, is that reactive as well?
I think if you take away the weight, now it's anticipatory. Because we've already established that their balance is affected
Right.
in some way. It's just how much. So what we're doing is we're bringing these interventions. And largely the debate comes to an academic standpoint. It's saying, does the student know how to describe this? Will you ever have to? I mean, the thing is I don't think you're going to get goals past balance many times in your patients when you're out there doing your thing. But if those goals state that patient needs anticipatory balance, do you know how to address it?
Right. Okay.
And so what we're trying to do is simplify the process for you to say, I'm going to do sit stands, I'm going to do sit stands with rides up on toes, and I'm going to do single leg stands for anticipatory. For reactive, I'm going to bring in these sets of perturbations. Right here.
Okay. I got you.
All right, so Aaron, you grab a seat. So now we're at sensory orientation. Let's just see what that says. The stance is feet together, eyes are open, they're on a firm surface, right? So let's kind of talk some more about some of that language. Firm surface tells us what kind of balance are we going to be doing?
Static.
Static. Firm surface is the same as saying stable surface. And then the eyes are open, so we get visual input. Place your hands on your hips, place your feet together until almost touching. Look straight ahead, be as stable and still as possible until I say stop. This is otherwise known as quiet stance. And as long as they can do that for 30 seconds, then they get normal status on that test. Flip over to the next page. Now, and I don't quite understand why they make this big jump in the gearing here, but they go from a firm surface, eyes open, to a foam surface, which makes it unstable, which makes it what? Dynamic. And the eyes are closed, right? Do you see how they do that? I mean, that just seems like an awful big jump to me, but we're going to go with it. And it says the same thing. Step onto the foam, place your hands on your hips, place your feet together until almost touching, be as stable and still as possible until I say stop. And again, they're looking 30 seconds there. Now, this one I really like because it puts some new cueing into some of the questions you've had on somatosensory. We're going to put them on an incline ramp, right? So we don't have one in this room. We really don't have one in the lab either. But I want you to think of a wedge and standing on a wedge. And when you do, you're placing that foot into dorsiflexion, right? And so a little bit of elongation through the gastrocs and the plantar flexors. And it says that you're going to step onto that ramp and then your toes toward the top. Place your shoulder width apart, or your feet shoulder width apart. Have your arms down at your side and close your eyes. So what are we doing there? We're really taking out the visual input. We're pushing into vestibular, and then also we're challenging our somatosensory, right? So you see, that's just another sequence we could put these all into. So when you're looking at the whole picture again, look at how you could use these in interventions though, right? Instead of just saying this is a test, we could use this as an intervention. Here's another example, and I'm going to step away from the paper for just a minute. Actually, no, I won't. But I'm going to fast forward. Go all the way down to number 14. And you've seen this one before, the tug, right? It's an assessment. And to kind of give some perspective to this, it says 3 meters. 3 meters is approximately 10 feet. It's just under 10 feet, just a little bit. And so these square tiles right here are 2. So I could do 1, 2, 3, 4, 5. So basically, from me to Vanya is the testing distance. So what do? I stand up from my chair, and as soon as the patient rises, we hit the timer, right? And they're walking, and they have to walk. They have to turn. So vestibular is being challenged. And then they have to walk back, turn again, and then until they sit, we don't hit the stop button, right? So this one, we're looking to accomplish within 20 seconds. 20 is going to start speaking about risk. 30 says high risk. We've seen the tug before. But let me back up and go this way with it. The assessment's over there. Now that I know what to do though, what if I use this in my therapy? What if I said, part of what we're going to do today is we're going to have you here, we're going to put a marker out there, and what I want you to do, sir, is I want you to stand up, walk, turn, and sit. Now here's what I'm trying to do, is I'm trying to give you some hard, fast treatment options to do with your patients who have balance problems. It's not always just got to be an assessment. We can use the test to intervene on their problem. Are you following? Like instead of just saying, well, we have Tinetti, we have Berg, we have tug, we have all these other tests we can do, why don't you use those? And I'm not just saying for skills check. What I'm saying is when you have a balance patient, why aren't you using these things? Okay? And the same will be true next week when we go over gait. Like we're going to do normal gait, abnormal gait, and then gait interventions. And I'm going to show you the dynamic gait index. And one of the things that you get to do is you'll take a patient, for instance, and you'll walk them, and they actually have to walk and then step over an object, right? And then continue to walk. Use the test as an intervention. And then you most commonly will have access to a Tinetti or a Berg. Grab that Tinetti again. Open it up. What if we have our patient turn 360 degrees? All right, so what's that mean? That means they're going to do this, right? And what did we put the standard on? Are they steady, unsteady, continuous, or discontinuous? Well, you look at it and you're getting that input back. How do you cue them? Make sure you're continuous with your steps. Come on, keep going. There you go. All right? And they turn. That's just part of your intervention right there. Use those things as part of your intervention. And that's really what I want to push into today, is take the test and make it your intervention. Right? So we've talked about a lot of things. What about OTGO? The home exercise plan we covered in lab, remember? Starts off with what? Long arc quads. And then they stand up and they walk over to the counter and they do hamstring curls, remember? And then they do mini squats. And then they do hip abduction. These are all just part of the sequence, right? So you're just filling in the blanks. All of your treatment right there, here, we're just bulking it up. We're just bulking it up. So here's what I'm pressing into. Next semester, you're in Therax 2, we're going to be like making all these therapeutic interventions for total knees and shoulders and all these things. And you're going to be like, yeah, I got that. Now go back and think, how many of my patients have balance goals? What can I do to address those balance goals? We've given you a whole gold mine of things to do. But if you don't have anything specific, go to the Tinetti, go to the Berg, go to this mini balance test, go to your OTGO, grab those things out, put them in place, and run your patient right through those. And you're good. Thoughts or questions on that? All right, join me in the book and let's cover just a few more little things before we end this. On page 270, it talks about the outcome measures for all those tests that we just did. And again, it starts with Berg. 56 is your max. It says less than 46 is your cutoff score for risk. So that's a 45. Tinetti, 28. And then your cutoff score is less than 19. 18 would be a high risk. Go ahead and change over now. Let's look at page 277. I want to bring you back into the OTGO again, just in case you missed it on lab that day. It's listed out on page 277. It's even bulleted on page 279. There's a box 8.4. Gives you all of those steps again. And then turn to page 282.
Kendall, I have a question.
Right on.
GMG, do you want us to write everything out for the home exercise, or can I just write OTGO home?
I would like to see you bullet out those things so that you
Okay.
know what they are.
Okay.
You don't have to give very specific details about it, but knowing where we start with long arc quads, we go to hamstring curls, we go to squats, we go to hip abduction, and then we go to the gait training exercises of tandem walking, lateral walking, backward walking. All right, so I just want to kind of push you into these three real quick, and that's on page 282, ankle springs. So when we see ankle sprains, many times in clinic, we're gonna treat them very methodically by saying, okay, you have an ankle sprain, you have some swelling. What are we gonna treat with swelling? We're gonna put some ice on it, we're gonna put some compression on it, and then we're gonna start our ankle sprain regimen, and that many times looks like exercises with a TheraBand, right? So they're doing dorsiflexion, plantar flexion, inversion, knee version, all with a TheraBand. But why don't we bring in some of these concepts with balance that we just talked about? So ankle sprains are a great place to land. It says in your book that successful programs utilize wobble or unstable balance platforms, single leg stance progressions, resisted kicks of the uninvolved leg against an elastic band. So what do you think that looks like? Resisted kicks of the uninvolved leg. Right, so Dakari, can I borrow you for a minute? Remember, we're doing some pretend work. I forgot to get the band. So he's standing there, go ahead and turn away from me. Let's pretend his left ankle was involved. And by the way, if I'm working with a lower extremity patient, I really like to work them with those shoes on. I like that floor to foot contact to really give that input in there. So we're gonna pretend he doesn't have a shoe on. His left leg was injured, so the uninvolved side, I put a band on. So Dakari, I want you standing up big and tall, and I want you doing some kicks. So you're basically gonna be doing this action right here, okay? So let's pretend I have a band, right? And I'm down here like this, and I'm holding the band, and he's pulling away that band, right? Go ahead and take a look at what his involved ankle, the left side, is doing. Now come back down and back up. Take a look at the input that his ankle is having to go through, right? And back down. And now he's resisting this leg, right? So that's a great one to do. Forgive me, I forgot the band. So that would be a good option. Another one on our list, it says, programs typically were conducted for at least 3 times per week throughout a competitive season for prevention, or 2 times a week for approximately 6 to 8 weeks post-injury. So we can look at this in a preventative technique as well. So it's probably not a real common thing that PTAs jump in on the prevention side of certain things, but we can see that plays a role. Look at the next one, and that's our anterior cruciate ligament injuries. The ACL says proprioceptive and balance training programs, either alone or in combination with neuromuscular training that includes lower extremity plyometrics, trunk stabilization, strengthening, and sport-specific functional training have been shown to reduce risk factors and the incidence of first-time non-contact ACL injuries. Go on down to the very next statement. It says, these proprioceptive and balance training programs frequently consist of double and single leg balance exercises progressing from firm to unstable surfaces such as ankle discs, tilt boards, and by the way, the ankle discs, that's what we showed you the other day in lab, the green and the blue, the black, and then we have some blue ones back there, and I don't think did I ever drag those out? I didn't. Those are the ankle discs. Tilt boards, or foam with variation, such as squatting or catching a ball. So take a look at some of the pictures up there on the BOSU A, B, and C above that, and you see what they're doing. And then turn the page to 284, where it talks about low back pain. And I want you to see and about the second statement under that paragraph. It says specific spinal stabilization exercises consisting of voluntary contractions of deep abdominal muscles reduce pain and disability and produced immediate and long-term improvements in postural adjustments in people with chronic non-specific low back pain. And so our very first landing place in Therex 2 is all about the spine. And we do lumbar, thoracic, and cervical spine. And so one of the things that we're going to talk about is that deep abdominal strengthening. But in the same respect, think about what the low spine muscles, lumbar spine muscles are doing during posture, but also during balance. And one of the things we can just think about what Dakari just did there, just in a very slow, very methodical movement, kicking against a band. Think about what has to happen here. He has to stabilize significantly here. We saw the ankle moving, but think about what's happening at the trunk. So what I want you to do is I want you to stand up and I want you just to try this. And just swinging that leg up and just try to think about what that would feel like if you were resisted. And now I want you to think about what you're feeling right here. And right here. In fact, go ahead and put your hands down on your low back if you need to. Right? And no doubt you're feeling that in your glutes and in your hip flexors. But we can bring in our balance interventions for our low back patients as well. And we should. All right. So, do you have a plan now for your skills check?
I have a question.
Wait on.
So, you know, on the very first one, it's just static sitting. For the visual challenge, you like want us to just like sit them there with their eyes closed.
What do you guys think?
We can use those stuff on the topic. Remember that package you did on one of the visual
But I just know like with the static seated part though.
That would be taking out the visual.
Challenging the visual, right? If your eyes were closed, you just said that, I thought.
Yeah, that's what I was asking earlier. Because if you close the eyes, you're challenging the vestibular and somatic.
Correct.
So it would be challenging the visual.
Right.
So you can just have them do like moving their head.
So to challenge the visual, you would just be moving the head then?
Yeah, because then you're taking out the vestibular and you're challenging the visual to keep your balance.
Right.
But what does the skills check say?
It says static, seated, balanced for the. It does both.
Right.
I guess I was under the impression that if you were working on vision, you take vision out.
If you are working on vision, visual input, then what you want to do is you want to challenge the vestibular side then by turning the head. Because now what you're getting is visual input to maintain balance.
Okay. But your eyes are closer or not? Or,
I don't know, are they?
well, I thought so, but now I'm all confused.
If you close them though, then you're not using the visual system.
Mm-hmm.
Yeah.
Okay.
Now, what you have to realize is that sometimes we will take both of those inputs out of the equation. And what does that mean? That means the somatosensory has to upgrade. It's all about what are you upgrading in response to taking something out.
So if I do this is visual and vestibular, correct? Because the head is moving and the eye? Or
Yeah, but your eye is for level gaze.
Okay, so you'd have to keep it straight in order to do that. Okay. But then you close it and you're just doing vestibular
Right.
and somatosensory.
To challenge or take out visual input, you have to close the eyes. I mean, right now you're swinging your head, so what are you doing?
So like visual and vestibular.
I'm still kind of confused on it.
That would
Like the
be,
static seated, so if I was challenging the visual for static seated, would I move my head like four-way head turns? Or is that for the vestibular?
For our skills check. Now keep in mind, does anybody have one? Let's pull up real quick. When you look at it and it says the SPTA, seated and visual challenges, right? So what you're wanting to do there, and this is just for this skills check, what I'm asking you to do is keep that patient seated. Are you guarding them? Do you have them placed in the right position seated? Or did you put them right here? Now this is incorrect. Why? Because my feet are not in contact with the ground. Okay? So I'm looking for you to know that you can't do this right here with a balanced patient. I'm also looking for you to have that patient in a gait belt and that you're guarding them correctly. And then the last thing I'm looking for this specific thing is for you to take a visual input out.
Okay.
Which means what?
Close eyes.
Yes.
That's for the vestibular challenges?
This is for visual challenges. Take out the visual input.
Okay.
For the vestibular challenges, you're going to have to move the head somehow. How do you do it? That's up to you. I want to see that you can. As far as what you're saying, and I think where the confusion is coming in is, if I take out the visual challenge, what do I see come up? Or if I take out the visual input, what do I see come up?
Right.
And that's vestibular and that's somatosensory. Why? Because the job of the body is to maintain balance. Right now, my eyes are open, right? And definitely my somatosensory is getting challenged. Why? Because my feet are not on the floor, but just my trunk keeping me up and I have no support around me. If I close my eyes right now, Hikari, tell me, what's keeping me up?
Be somatosensory. And well, are your feet onto the second bar? I can't really see. But,
My feet are nothing.
okay. So,
They are suspended in space.
Yeah. And vestibular.
So I'm getting somatosensory through my hips. I'm not through my feet, but I am through my hips and into my trunk. And I'm also getting vestibular, both keeping me from doing this right here, right? Now, again, just like